There has been a quiet revolution going on in the way we house and care for people with dementia. Once upon a time, people with dementia or other cognitive impairments were put into a large hospital-like institutions that most people called nursing homes. Nursing home facilities did provide a safe environment, and they did provide for patients' medical needs, but they were based on an institutional medical model of care, and they rarely provided for people's cognitive, sensory, social, emotional, and spiritual needs. Today, long-term care facilities are being reinvented. Nursing homes are giving way to community living centers. Staff are striving to create home-like settings, and they're working to engage residents in a broad range of activities that are truly meaningful to them. These activities will be the focus of our broadcast today. Hello everyone, I'm Fields Mosley, and welcome to our broadcast. Over the next hour, we'll talk to three experts on continuous, meaningful activities for veterans with dementia. We'll delve into such topics as what continuous, meaningful activity means and why it's important in caring for veterans with dementia, how continuous, meaningful activities have been incorporated into clinical practice, how implementing meaningful activities has improved care for our veterans with dementia, and how implementing such a program is consistent with the transformation of care for people with dementia. Along the way, we'll be showing video footage of various continuous meaningful activities in practice, and we'll give you a chance to call in with any questions you might have. We'll have that number for you a bit later on in the program. First, let's meet our guest today. First, on my left here, Scott Trudeau is an occupational therapist, research scientist at the Geriatric Research, Education, and Clinical Center, or GREC, at the VA Medical Center in Bedford, Massachusetts. Carol Phillips is a staff nurse at the Community Living Center in Richmond, Virginia. She has worked with people with dementia for the past 15 years. And Mary Nash is the chief nurse for long-term care in the VA Miami healthcare system. Welcome to you all, and thanks for being with us today.
Thank you.
Well, before we go ahead and talk to our guests, we need to make a few quick announcements. This program is produced by the VA's Employee Education System in partnership with the Geriatric Research, Education, and Clinical Centers. Additional information about this broadcast, including the faculty, the planning committee, and the graphics used in our presentation, is available on the World Wide Web. VA users, as always, can find this information at vaww.lrn.va.gov. Scott, let's go ahead and start off the conversation with you. Tell us about how the philosophy of meaningful activity is changing the way things go at CLCs.
Well, I think you mentioned in your introduction that there's been a shift probably 15 years or 20 years ago even, away from nursing homes being medical institutions and trying to make those environments more home-like. And as we changed and evolved the environments, we began to recognize that the environment itself doesn't make all the difference. There's something else that goes into protecting and preserving the quality of life for people with dementia. And we've come to understand, I think, that that's really continuous, meaningful activity.
So what kinds of functional deficits might prevent people with dementia from participating in meaningful activities in daily living?
There's a lot of deficits that result from dementia. Dementia is, of course, a neurodegenerative disease process. So the neurological system that gets impacted by the cognitive decline of dementia is the same neurological system that's involved with accessing all of our motor planning and our ability to do activities in our daily life. So some of the functional deficits that specifically are important to meaningful activity with dementia residents, the first one I think of is paratonic rigidity. This is a process by which the neurological system forces the individual to sort of retract their muscles when stretched out. So in a situation where a nursing assistant might, for instance, be trying to get someone's arm through the sleeve of a shirt, they might sort of guide the arm forward. The resident will neurologically pull back. This often gets confused for being resistive to care, and so that becomes a real issue around managing folks with dementia. Another issue functionally that concerns us is a concept of excess disability, that through the process of dementia itself, there are certainly resultant changes that one could consider disability. But the environment and how the person is, the expectations that are placed on the person also have a contribution to that. And sometimes if the environment is too supportive, we call that a situation where excess disability is present. More disabled, the individual is more disabled than they would be necessarily from their dementia. Another issue for folks is a lack of initiation around mobility issues. The person isn't processing the environment the same way. They're going to have less of a tendency to just get up and go on their own. This can lead to the next factor, which is deconditioning. The more sedentary an individual is, the less physically able they become because the muscles will deteriorate and will waste away. So it's a really kind of a vicious spiral. And here, in terms of deconditioning, we also see people, once they're labeled with dementia, who fail to be challenged cognitively. People, again, sort of assume they can't do things before giving them the opportunity to do them. And that can lead to a concept of learned helplessness. The person stops trying. Another area of concern is around sort of motor planning and initiating movement. Apraxia and balance disturbances can be affected, which can cause significant changes in gait and ambulation, which results in often our staff trying to protect the person from falling instead of encouraging them to walk independently. Pain is always an issue that needs to be considered in terms of functional status, and the VA has pain as a fifth vital sign for a reason. It's difficult to ascertain in folks with dementia, but it is possible to assess even late into the disease. Comorbidities for all older people, but especially with folks with dementia, other diagnoses like arthritis that may impact their ability to perform functional activities comes into play. And then the last issue to think about is an issue of fear, that folks may not want to be embarrassed, they may not want to have their cognitive loss exposed in a social situation. They're going to tend to isolate and really retract because they're afraid of being found out, which can be problematic.
So how might meaningful activities help with these things?
Well, meaningful activity as a concept is important because doing really transcends all cultural barriers. And by that I mean that all cultures value an individual's ability to do things. Even in our own society, if we meet someone for the first time, we're often asked what we do. What do you do? It's not who are you, what's your name, where were you born, it's what do you do. So doing is really a culturally significant concept. Meaningful activity also helps us in that same vein to define ourselves socially. We have role expectations that are placed on us by what we do. We also see the importance of meaningful activity in supporting habits and routines. Sort of the flow of your life is driven by the activities that you perform. Within the dementia construct, we also have the ability to use activities to provide opportunities for manageable choice, to allow the individual to make a selection. Do you want to do this activity or this activity now? It really gives them it respects them as an individual and fosters a sense of dignity within the interaction. And then the last thing about meaningful activity that's important to understand in dementia is that we can really tap on procedural memory. Motor plans that are more deeply ingrained in the brain can come out when given the opportunity. And so again, things that we might not expect someone to be able to do, they're able to do because of procedural memory.
So how do meaningful activities relate to the totality of patient care?
The totality of patient care, the construct that we often use is a construct that we refer to as quality of life. And so we look to how do the factors within the CLC setting contribute to someone with a dementia and their ability to attain a quality of life within that space. Dr. Wolitzer and Dr. Bloom-Charette at the Bedford Grec developed a model of quality of life that's important to understand in terms of, I think in terms of advanced dementia especially, but they saw that the context of the CLC setting really having three components that needed to be addressed in order to effectively support quality of life. Medical issues and psychiatric symptoms sort of were the traditional concerns of a nursing home. So again, often the interventions for those would be medically based. But notice that meaningful activity in the conceptual model is actually on the top of the model. It's, in their opinion, and my opinion too, it's the most important, the most significant factor that can drive whether or not someone has a quality of life. And in fact, in the issue of depression, we know that meaningful activities are actually as effective as antidepressant medications at treating symptoms of depression in this population.
And at this point, maybe it's important that you explain what you mean when you say quality of life.
Quality of life is difficult to pin down, but it's a multifactorial concept that for folks with dementia, we can't ask them, how's your quality of life, and necessarily expect a valid answer, although it might be worth asking most of the folks we work with. But when we think about quality of life, we're thinking about the opportunity to promote engagement for the individual. Quality of life, again, if you think of your own life, my ability to get out and do things and to be part of society is how I judge how effective I'm being and how purposeful I'm being. And so it's the same thing for residents with dementia. They still need to be connected to the physical world as well as the social world. And so that becomes an important quality of life measure. Quality of life is also observed with the ability to decrease agitation. If people are comfortable in their environment, if they're not troubled by delusions and psychiatric symptoms because they're meaningfully engaged in other things, then that certainly contributes to quality of life. Meaningful activity also provides opportunities to maintain mobility and physical condition for folks with dementia, which, as we said, is really important to prevent deconditioning. We're also concerned about maximizing each individual's ability to function independently when possible. So giving people the opportunity when it's possible to brush their own teeth or supporting them to do it as independently as it is possible can really go a long way to help preventing that excess disability we spoke of. Also, as I mentioned earlier, we see improved mood when folks have depression as a result of meaningful activity engagement, and the maintenance of dignity and independence is important to that quality of life as well.
Now, what's meaningful to one veteran might not be meaningful to another. How do you go about finding out what is meaningful to a particular veteran and then coming up with some personalized activities?
The process we use is a sort of a twofold process where the interdisciplinary team is involved with getting historical information about the individual. Who were they and what did they like to do? And that becomes important. In social work, we'll talk to the family, and nursing staff will interview family and the resident about their interests. Recreation and occupational therapy will consider some of the functional abilities of the individual previously. But then we have to take that individual into the context of the CLC and provide them with opportunities to explore some of the meaningful activities that are available, to begin to see what things strike their interest and what things are capable of engaging them. What's our hook?
Okay. And do you try to make those activities continuous, and how do you do that?
Well, when I think about this notion of continuous meaningful activity, I really think of this quote from Charles Kingsley. He's a clergyman in the mid-1900s, 19th century, excuse me. in Britain, and his quote is, "We act as though comfort and luxury were the chief requirements of life, when all that we really need to make us really happy is something to be enthusiastic about." And this quote resonates with this notion of continuous activity, in that it's really about what gets you out of bed in the morning, what is the purpose of my existence. And people with dementia still need to have that purpose. And I think that's pretty cutting edge for folks to think about. So the simple things that are available in the day-to-day activities become very important. And it's not just the big special events, the luxuries, if you will, that are important. It's really every interaction, every opportunity to be engaged in meaningful activity.
Okay. So what kinds of activities are best for people with dementia?
That's a really good question. I wish I could.
I'm sure there's a wide range.
I wish I could answer it easily. But when I think one of the things that we've talked about, the panel has talked about a lot, is this notion that if only there was sort of a recipe or a set schedule that we could export and would be appropriate for folks with dementia. And because of the functional variation and the need for individualized care in order to support individual quality of life, there is no such list. And so rather than thinking in terms of a recipe, there's some considerations that one has to take into mind when selecting activities. One of the first that I would recommend is that activities should be purposeful, familiar, and meaningful. We want people to be able to connect to something that's real to them. We want to be able to create activities that give some sense of immediate pleasure, that are not too challenging so that the frustration blocks their ability to engage. We want to have activities that focus on the individual's strengths and abilities and really minimize their disabilities. We want to have activities that really feed into the social purpose of my existence. Why am I here? What role am I fulfilling by engaging in this activity? Activities also have variable levels of social interaction inherent in them. We want to consider that. We may set up a situation where an individual or a group of individuals have to share supplies in order to complete a task, so that we're setting up the environment to facilitate some need for social interaction amongst participants. We also have a consideration around positive reinforcement. We want to be able to celebrate the successes, however seemingly small they may be, with the resident, to again foster that sense of purpose and self-esteem. We also, one of the things that comes into considering and selecting activities is the importance of the ability to grade activities to meet differing functional levels. And by that I mean the same activity can be made more difficult based on the expectations and the support and the direction within the environment for someone who's higher functioning, but then can be tailored down to be a little bit easier for someone who's lower functioning. And whenever possible, including folks in activities needs to consider that. We also want to, sort of as a standard activity tip, is to avoid multi-step activities. And if you use multi-step activities, to then chunk them into one or two step directions, so that, again, something like go down the hall and brush your teeth is too complex for most people with dementia, but come with me, let's go down to the sink. And then they go to the sink, and then the next step, and so forth. The other thing is that folks with dementia respond very well to repetitive and rhythmic activities. We see this in terms of most people with dementia respond very well to music, and so the rhythm of a particular activity can compensate for some of that apraxia that we talked about earlier. Other considerations in terms of activities include how much gross motor versus fine motor is involved with with the activity. Gross motor, you might have a more gross motor activity of playing balloon volleyball with a group of patients, but you then might have them also sitting down doing a beading task, which is more fine motor. And different patients are going to have strengths in those different areas, and that needs to be considered. It's so important, if there's one takeaway message I could leave folks with today, is that personal care tasks and group living tasks are part of meaningful activity. And so people being able to get up and brush their teeth, people washing their hands before meals, people folding napkins or setting the table, those are all chores and tasks that we all do on a daily basis in our own life, and they're important for that rhythm of the day construct. The emphasis on frequent outdoor activities, getting people, I mean, none of us spend 24 hours a day, 7 days a week within the same four walls. Why should we expect people with dementia to do that? We need to find opportunities for them to move to different spaces, to have different experiences, and outdoors to connect with nature, to get back to their roots, if you will, and no pun, or pun intended, I guess, is really important. Intergenerational program where children are brought in and to have an opportunity to interact, it can be very effective. Some of our residents will have at times socially inappropriate behavior, but when a group of school children are in their midst, the language cleans up, and you see them responding very differently than, again, you would expect necessarily for them to respond. And then overall, we need to continually sort of keep in mind the cultural contexts that are associated with different activities. Some activities may have religious significance, and we need to be sensitive to the needs of the individuals that we're working with on a cultural level.
Well, let's go ahead and bring Carol into this conversation. The Community Living Center in Richmond, Virginia has been implementing a continuous meaningful activity program for the past 10 years, right? Tell us more about that.
I'm delighted to tell you about the program. And our whole program is based on William Thomas, MD, and his Eden Alternative, and Teepa Snow's program on the different stages of cognitive loss. And both of those programs have been brought together and championed by our unit manager, Violet Oliver. So part of that program is that we have received the Eden Alternative certification, and we are the only one in the entire VA system to have that certification. And with the 5 cognitive levels, we grade different levels of activities for all of our patients, so that someone who is a 5 or a high functioning patient or resident with dementia can do more activities or have more challenging activities than someone who is a 1 or a Pearl. These are things that we do all the time.
Okay. Well, a few weeks ago, we sent a video crew out to Richmond to have a look at some of the continuous, meaningful activities they have there for the residents. One of those activities was horseback riding. And Carol, give us a little introduction here. Tell us about the horseback riding program.
We have a volunteer. He's absolutely wonderful. Clint Arrington is his name. And he has a farm, and he invites our residents out to his farm to ride horses, to get in touch with the animal, you know, to stroke the animal's fur, or to sit on top of the saddle, to do exercises while they're sitting on top of the saddle, and just to relate and sit up tall and enjoy the experience. He's, Mr. Arrington is quite a volunteer.
Sounds like he is a very special volunteer. Let's go ahead and take a look at this video clip.
In our facility, on a daily basis, each resident, we try to make sure that in their day, they can have something that they can do that they enjoy. So we make it patient-centered. Our program here provides for our residents opportunities for hope, for exercise and enjoyment. Riding horses for a lot of these veterans means that they have a chance to live their life to the fullest. And that's what we desire for them, a quality of life.
He is moving with the horse, and it's sitting up straight, and he's smiling from ear to ear. That's what I like to see.
Being outside gives them the fresh air, the interaction with the horse. You know, people enjoy interacting with animals.
They get the sense of confidence that they used to have. They get their courage back. Some of them come out there timid. Some of them have lost a limb or lost a leg. This helps them regain their courage and allows them to go forward in the future with other things. It's incredible.
He's a level 5 as far as his cognitive abilities. So for him, this is being able to do the best that he can at his level, and he enjoys riding. We're maintaining his abilities. At the same time, we're helping him to enjoy his life.
Very good stuff there. Carol, I understand there was another veteran there whenever the shooting of the video was going on, and he observed the horse and everything else. Tell us what happened. You had a little bit of an interaction with him.
I did, and I found it very interesting. This resident was sitting on the patio watching at a great distance the horse and another resident on the horse. And he said, "I would like to ride the horse." And he is known for not wanting to participate in any activity. So it really was one of those moments where seeing one resident participate jogged a memory in this man, and so now he will be going riding and the farm.
And Scott, I guess this goes back to what you were talking about earlier, just being observant and trying to figure out what will trigger something for a veteran with dementia.
Exactly. I think it's also a really nice example of the involvement of a community volunteer program. I mean, we talk about how can we do continuous meaningful activities. We don't have the resources. Well, we don't. One person, one program probably doesn't, but when we involve our community and we involve volunteers like this, we have a better chance of meeting the needs of dementia folks.
Okay. And Mary, do you have anything else to add after watching that piece of video?
Well, when in watching the video, I was pleasantly surprised to see truly evidence of no loneliness, no boredom, no sense of helplessness in this particular individual. And one of the things I was mindful of is something that Dr. Thomas said in some of the literature, in that we need to be committed to human growth. And you can see this individual has grown. He's able to do something that he has not done before. He's able to make the choice to do something that would be pleasurable to him.
Okay. Now, Carol, I imagine that a lot of your residents would be unable to participate in something like horseback riding, but they can perhaps do simpler tasks. Tell us a little bit about your gardening program. We want to hear about that.
Gardening. Everybody wants to get their hands in the dirt, and it really appeals to a mid-level resident with dementia. And you can see, and the other levels too, but you can see how much they really enjoy it. It allows them to feel the dirt between their hands, or to use a utensil, or to plant something, to watch something grow. And they do grow vegetables, and they do harvest vegetables, and at the end of the season they will cook their vegetables. So it's really worthwhile for them. You can see them following it all summer long.
And achieving some level of satisfaction out of that.
Absolutely.
All right. We have some footage of Richmond's residents participating in the gardening tasks. Let's have a look at that clip now.
There are two things that I feel that we do with our residents that really increases their quality of life, and that is we share our lives with them, and we give them opportunities to do real life things that are meaningful to them. In our gardening area, we have the wheelchair level planters where the folks who really can't walk around can wheel around and plant flowers, and they can watch them grow, and they can take care of them. And they become the caretakers for someone instead of being cared for. They have an opportunity to be the caregiver, to actually get outdoors and to touch the soil. So it's like the joy of spring. It's just springing forth everywhere. An opportunity for them to come outside. It gives them exercise. They get vitamin D. They have an opportunity to socialize. And you know, guess what? Play in the dirt. Who doesn't want to play around in the dirt? I think that those opportunities make the veterans feel like they're useful. They're doing something that's meaningful.
Well, the one thing I noticed whenever I watched that video clip is the variety of people who can participate in that. Now, maybe you can't ride a horse, but these gentlemen, they're in wheelchairs and everything, and yet they're able to get out there and plant flowers, vegetables, all the things you mentioned. What do you take away whenever you observe your program that you have going on and the success of that?
Well, that everyone can do something. There is some level at some point that everyone can participate in, and we just have to find the key.
Okay. Mary, anything that you took away from that last piece of video?
Well, one of the things that was very evident there had to do with the fact that it's resident-centered. It's centered around the individual needs, the individual abilities of the persons involved. That was very, very evident. And the other thing that I really liked about that video is the fact that throughout some of the things that are happening at Richmond is about community. You see it all the time. So that even when a resident cannot complete a task himself, of course it may be that he was graded and you knew that he couldn't complete it, but there was always someone there to assist or to help that person to complete that task and to feel successful in getting it done.
Okay. Scott, anything else to add?
Well, our program, we work with end stage, really later stage residents, many of whom couldn't even do this level of activity we saw in the video. And yet we're using gardening with a volunteer connection that we've made with an Eagle Scout candidate to provide sensory experiences for our residents so that their family members can take them for walks outside and they can experience a garden with many different tactile touch experiences or visual experiences, different colors. And we're going to have sort of a guided tour so that family members can follow the tour and use that as a way to facilitate interaction with their resident, which is also often very difficult, especially in the later stages.
Okay. I'm guessing, and we've talked about this a little bit, that gardening is also beyond the cognitive abilities of some individuals. What about simpler tasks? What about just playing games, maybe cards, something like that? Carol?
And you're right. Some of those tasks are above some of our residents. But our residents have long-term memories, procedural memories, Scott calls it, and they can remember how to play checkers because they've played checkers for 80 or 90 years, or card games because they've played cards all their life. So these are the type of activities that we want to tap into because they still enjoy them, and we just want to facilitate that.
Okay. Well, we do have some footage of veterans in Richmond playing some games. Let's have a look at that.
Cultural transformation is the difference between a nursing home and a community living center. With our facility, we look at the person on a holistic, patient-centered concept. So much so that when they arrive here, the first thing we want to find out is, what do you like to do? What are your hobbies? What do you enjoy? What makes you laugh?
One of our goals with the Dementia Unit is to provide as many stimulating activities for patients as we can. Social interactions in the dining room is one of the things we do provide. I believe it helps them maintain as normal a functioning life as possible. So they may have dementia or they may have another disease process in addition to a dementia, but we try to give them the best quality of life that we can. And that best quality involves a lot of interactions with other people.
It's important because the quality of a person's life is not just receiving medicines. It's not just making sure that their physical needs are met, but that their entire needs are met as a person.
I have heard much about Jesus. Oh, I must see Jesus just to say he loves me so.
Very nice, very nice. That was very nice. That was wonderful, Mr. Harris.
All right, first, Carol, you have to explain the song there.
Our resident is a pastor, or he was a pastor. He still is in his heart and soul. And he's also a wonderful singer. And he's been a volunteer at the VA hospital for a long time as well. So this is a long-term memory for him. This is a procedural memory. And he remembers how to sing beautifully.
Well, you touched on this before, but it still surprises me when you watch people with dementia play checkers. My grandmother had dementia, and she could still cook a meal all the way up until her death. But that was kind of all she could remember to some extent. Talk to us a little bit about those ingrained memories. Tell us a little bit more about that.
Well, they are. They're memories that have been placed in their brains a long, long time ago, things that they don't ever forget. We have a resident who remembers his address from when he was a child, and he's 90 years old, and he still remembers it. And he asks us some days to take him to Quantico, and he'll give you the address. So he'll never forget that address. It's just part of his being.
And that's just something what was the term used?
Procedural memory.
Procedural memory. So that's just something that brings back checkers, brings back card games, brings
Absolutely.
back songs. Okay. Well, obviously we didn't show all the activities that you have there at the Richmond CLC. Maybe you want to briefly describe some of the other activities that you do with residents?
Well, we do have activities in with meal times, and people, our residents and staff go to a patient dining room, and they can help a patient eat if they can't feed themselves, or they can set them up so that they can do as much as they can, or they can just open a carton of milk for them. It's exactly as much as they need. They use cloth napkins, and they participate as much as they can. There's also our den, our dementia engagement nook, and it's a wonderful room filled with special paintings, again by a volunteer, activities of all kinds, and even start with early morning coffee, which a lot of our residents remember. We have a spa experience, which is in our congregate bath, like a lot of people's congregate baths, but we turn the thermostat up so it's warm inside. It has soft jazz and has aromas of like special shampoos and conditioners and stuff. It gives a good feeling. And for the ladies, there's even a shampoo bowl that they use. And on every Friday, there's the ice cream parlor. And there's a jukebox, and it's a red and white place, and they set it Formica countertop tables or in a booth, and everybody eats ice cream at a certain time on Friday afternoons. It's just a wonderful event. Brings residents, families, staff all together in the same room or area.
So what do you do for someone whose cognitive abilities have diminished to almost nothing?
And that would be a very low functioning resident. And you have to go and try and reach them. You try the sensory things, and you try for like taste, and you want to see if they like ice cream or pudding, something with a smooth texture, or if you know if they've had a favorite food, the family might bring that in. And we'll ask families to like bring in some of their favorite music or family photos, something that will reach them from before.
Okay. Well, Scott, I know you've worked with this type of patient over the years. Can you tell us about some of the ways that you try to engage them in activities that are very meaningful?
I think, again, especially for the later stage or the lower functioning patients, the sensory approach is really very important. But it's also important to appreciate that connecting with someone through a sensory experience is not the end into itself. It's really the ability to connect, and then once you're connected, to sort of find some meaning in that moment. I always like to use the example of a resident who, one morning I was doing a sensory group, and I had some warm gingerbread muffins, and I opened the tinfoil and I asked the residents to smell the warm muffins. And this particular resident had been mute for nearly a year and a half. He hadn't spoken a word. And he sniffed the warm muffins, and he looked me right in the eye, and he said, "There's molasses in there." I nearly fell over, but and it wasn't just because of that sensory experience. It was then he was opened up. We had opened a pathway for him to connect and stay connected, and he was able to speak that entire morning, so much so that we were actually able to telephone his wife, and he had a conversation with her over the phone, which hadn't happened in a year and a half. It's pretty powerful stuff.
I'd say so. Mary, I want to turn to you now. You've been involved in a transformational change to continuous, meaningful activities in Miami. Can you tell us more about that?
Yes, we are so excited to be part of this revolution, because it truly is a revolution. In Miami, we've done quite a few, made quite a few changes, and some of the things that we have done that brings meaning to the lives of the individuals in our CNC is that we have different, not just activities, but also, as Scott has alluded to before, talking about meaningful activities that helps the resident to get through the day. The same things that are important to us and meaningful to us are certainly meaningful to them. And so one of the things that we're trying to do is to make sure that when, especially the direct care providers are providing care for them, that they allow them to do as much as they can for themselves. That's extremely important, because what they want to do is to contribute to the CLC, contribute to society, just like we do. One of the things that we have in our CLC, we have something called a council leader group. And what we've tried to do is to mimic the same council leaders that you will see in your towns, in your cities. And this group is a group of very powerful men. They make a lot of decisions, and what they do is they want to make life better for the rest of the residents living in our community living center. One of the things that one of the residents did prior to his death is that he championed providing postcards for all of the veterans in the CLC, because he believed that they should have some way of writing to family members, to friends, and it didn't even have to be a letter, because some of them couldn't do that, but they might be able to do something very short, hello or whatever. And so he did all of the groundwork in terms of going to all the right places to get this done, and it is used in our CLC. So just to see him to be able to be successful at that made such a significant difference for the resident. It did for his daughters, and it also did for the staff in the CLC. The other thing that we have done that I think that's just absolutely wonderful is providing a fine dining experience. And one reason why I like to share this experience, and I've shared it before, is because within a community, you know, we're just a microcosm of what we see in the real world. And so we allow the residents, some with dementia, some with not with dementia, but to have a fine dining experience with our executive leadership team. And that was awesome. And matter of fact, the residents talked about this for days, and some of them still talk about having had that experience. So what we want to do is say, regardless of where you're living, you have meaning in your life, and we value the contributions that you make. And so that's what we want to do when we talk about a holistic approach. We want to look at the entire individual and take care of them holistically. And that's our approach to saying, for each individual, we're going to look at what your needs are, and based on what your needs are, what your interests are, what your desires are, and we're going to create or work with you so that we can allow you to have some of those experiences. One of the other things that happened that we were quite proud of is one of our residents from the council leader group actually called I think they actually called 2 theaters, but one of the theaters I know that he called and he asked for tickets because the residents wanted to go out to theater. Well, most of the time we bring that into the CLC, but our residents are empowered. They have a lot of autonomy, which is where we want to go with the transformational change. And so what he did is he was able to work with the individuals at the theater, and now they get tickets and they're able to go out to the theater, which has made such a significant thing. The other thing that's really interesting about that is that when they go to the theater, the staff go to the theater with them. So when we're talking about having a commitment to the human growth, that is extremely exciting to me and to the rest of the leadership at our CLC. The other thing that I would like to share with you about is recently we had in February, we had a Valentine's Day ball. And that ball was absolutely outstanding. It was awesome to see residents talk about, I don't know, the last time that I've gone to a ball or I've been where they've had a band, you know, they had a jazz band there, and the executive leadership group was there as well, and they assisted with the feeding. And one of the experiences that we tried to give to them is that when you go to a fine restaurant, usually they don't bring the food for each person individually. Usually they will all give the food, place the food on the table at the same time. And we were able to give them that experience, which was really quite wonderful.
Well, I think it's clear from the footage we've seen that continuous meaningful activities are enjoyable for residents of the CLC. But I want to talk for a moment about why this is better care than that provided in traditional nursing home environments. And Mary, you've touched on a lot of this already. I know that you've been looking at the research about this. What does it tell us about that experience?
Well, there are significant benefits for it. It's significant for the resident. It is significant for family members. It is also significant for the community within the community living center, and it's significant for the community external to the VA. And it improves staff satisfaction significantly. And I'm very proud to say that we've seen an improvement in even the management of the residents, so that when we've had other kinds of challenging behaviors, we've seen those just go away. And one of the things that I would like to share with that I think that makes the continuous activities so meaningful is the fact that we have a consistent assignment. Consistent assignment is extremely important, and I think that it is the bedrock or the foundation for building the relationships that we need to see in CLC and in this transformational change.
Well, let's take each of those things one by one. How are continuous meaningful activities significant for residents?
Well, one of the things that we have seen, and actually is a goal or aim of ours, is that we want to have the resident maintain their dignity. We want them to have the respect that's due to them. And when we see that they feel that they're respected, it makes a significant difference. One of the stories that I'd like to share with you is we have a resident apparently had a significant job prior to entering into the CLC. And in his younger life, he used to dress every day. And he didn't dress casually. He would wear a tie, sometimes a suit or whatever. And so he had challenging behaviors, and we didn't quite understand why those challenging behaviors were there until we found out about how he liked to dress. And so now what we do is he dresses. For the most part, he wears a tie. You'll see him in a tie for many days, and in a shirt and a nice pants. And whenever he goes out, for example, during our Valentine's Day ball, he was absolutely awesome. He had on a beautiful black shirt and wonderful tie that matched, and he felt so good about himself. And you could just see that on his face and how he interacted well. And we don't see those challenging behaviors anymore, because he feels, he understands and he remembers the way I used to dress, and this is what I want. It's my choice. It says that I'm empowered. It says that I have the autonomy to do the things that I want to do when I live in this home, and so we're really happy about that.
Well, how are the continuous meaningful activities significant for residents' family members?
I believe that if I would say that it's significantly beneficial, because if you could just think for a moment about leaving a loved one, someone whom you have loved, someone, the person who's cared for you all of your life, and all of a sudden you're unable to care for them, and so you have to take them to another place for someone else to care for them. And I believe that it's very burdensome. And when a family member can bring their loved one to a place such as our CLC and see that we have a passion for what we do, we truly love the resident. That is not a word that we just throw around. We're not cavalier with it. We really do. And when they see that we really care and that they live in a home-like environment and all the other activities that surround that veteran, I believe that it is a significant benefit for them. They can go home and not have to worry about, well, I wonder what's happening to mom or what's happening to dad. So I think that that's a significant benefit there.
What about for the overall community?
For the overall community, earlier conversation with Scott, one of the things he reminded me of was about the community within the CLC. And we look at the community as our citizens. Our staff's part of the citizenship, and so are the residents and also our suburbanites, individuals who don't work there but who come in. And one of the things that we see is that's so significant is inclusion. They're included into all of the activities. For example, when we determined that we were going to name our CLC, everybody got a chance to come in and vote. It was just as if you were going to vote for the president. And some of the activities that we have that are planned activities, other people get involved in it. And one example that I had shared with the panel previously is that our housekeeping staff are awesome. Not only do they become buddies for some of our residents, they're assisting coaching them and cueing them when it's time for them to eat. So when we talk about community, we're seeing a lot more unity among the individuals who live and work there.
Does it also help with job satisfaction among your staff?
I believe that it does. And the measure that I use to satisfy that is we look at our all-employee survey scores, and which has gone up or increased significantly over the years. In 2010, on our CLC1 unit, on the scale of 1 to 5, their average score was a 4.57. And on our CLC2, the average score was a 4.33. And on our long stay unit, was a 4.3. And all of those scores are very significant, especially when you see how they have worked over the years. And we're not talking about something that I did, we're talking about something the staff did to bring those scores up. So I think that tells me that there's something meaningful that's going on, not just in the lives of the residents, but it's meaningful for the staff as well.
Do these continuous meaningful activities also make it easier to manage residents? You touched on this a little bit, but I was hoping you'd explain a little bit more.
Absolutely. Matter of fact, the gentleman that I spoke about with the vocalization, that was one of the examples that you saw that there was a change in behavior. Now, we also see that there's reduced anxiety among the residents. There's a reduction in falls, especially in certain neighborhoods. There is a reduction in other challenging behaviors, and it's evident when they go out to lunch. For example, the council leader group have business meetings, just like you or I may have a business meeting, and they go out to lunch at some even elite restaurants to have their meetings, and we don't see those behaviors at all. And I believe that residents know that we value them, we value their contributions, and we look to them individually so that the care is individualized. So if you have a particular need or one of the residents has a particular need, we're going to devise care around whatever that individual needs. And so I believe that that has indeed improved residents, and you don't see the anxieties, you don't see some of those vocalizations anymore, and you don't see, which is something that we had some previous problems with, you don't see the aggression from residents to staff, the aggression between residents on residents. So it has made a significant difference.
I know you mentioned the housekeeping staff was involved in this. Who's involved in implementing these programs? Everybody?
Everybody. It's all hands on deck, and it truly does take a team. And I think that our CLC is not much different from Scott's or from Carol's. I think that we use an interdisciplinary approach to implementing the programs that we have. So we have recreation therapy, which does an outstanding job. At our CLC, we have occupational therapy, we have nursing, of course, we have social work service, dietary, we have the family and friends, and we have volunteers. And one of the examples that I shared before was that we actually have a family member that's on our quality improvement team. And so we value what the citizens, the input from the citizens within our CLC.
Okay. Well, Carol, I noticed in the video clips from Richmond that a number of staff members were leading these activity groups. Were these all nurses or therapists?
Well, in the particular clip that we saw, they were mainly nursing staff, but it was RNs, LPNs, nursing assistants, but everybody gets involved. It is very much a team approach with recreational therapy, occupational therapy. We have kinesiotherapy. The social workers, dietary, families come in, they have friends who come and visit. It's lots of volunteers. It's really a team approach.
Okay. Well, so you're asking staff to perform tasks that are well outside of their normal experience, especially if they're in a hospital setting at some point. How do you get them to feel comfortable with all that?
Well, everybody has an activity that they enjoy doing outside. Some people like music, some people like movies, some people like gardening. I like gardening. And so we will do an activity with residents that we enjoy ourselves. We can share. There's a staff member who really likes sports, so they talk about baseball almost exclusively with one resident. And it's just wonderful. They share what you know.
Well, although it's clear that change is good, change for many people, of course, is scary as well. Mary, how do you help people overcome their fear of change and get by that?
You know, one of the things that I think that I would say, not one of the things, but the most significant thing had to do with the transformation that happened in me, the philosophical change. So once I understood exactly what the journey is, why am I on the journey, how is this going to impact the vision and the mission for not just our VA, but for VHA, that made a difference. And one of the things that happened at our particular VA is that we had a consultant to come in to assist us with jump-starting our transformational change. And that was pretty significant. But when that person left, you know, it's really up to us. And so what we try to do is we find that education is extremely significant. One of the things that I said previously was something that Dr. Thomas had said about a commitment to human growth. Well, we're not just talking about the resident, we're also talking about the nursing assistants. We're talking about the LPNs, and we're talking about the family members, so that education is extremely important in everything that we do. The other thing that we have found that has made such a significant difference is reward and recognition. When individuals do things right, they do a very good job, you need to recognize that immediately, and you can reward them. It doesn't always have to be money or monetary. There are always kind of ways that you can actually reward those individuals. One of the things about our council leader group, something that they have done, they came up with their own award ceremony, and they have a club called the Second Mile Club, and they give out the certificates of appreciation at town hall meetings. And recently, I think it was last November, we had a summit. And during that summit, not only did they give it out to the staff members, but they called in their bosses. And the chiefs of their services came and they received a certificate thanking them for supporting their employees that support them.
Okay. Have you experienced pushback at all from staff or management, and how did you deal with that when it happened?
Yes, I did, and it was a good lesson learned. And when that occurred, it was really had occurred because we had not included the staff in the change. The example that I would give to you that was really I won't ever forget is that we wanted to change medication administration times so that it was more like what we would do if we were in our home. We would not wake up during the night to take medications. And so we had a team that worked together to make that change, but we didn't take that to the nurses. So the nurses actually thought that they would be out of a job. And you want everyone to feel encouraged, and you don't want anyone to be depressed about, well, we're doing this change, but it leaves me out. And so I really learned a valuable lesson about that. And so now I know that if we're going to make that kind of a significant change, we need to involve everyone from the beginning.
Okay. Part of the continuous meaningful activity concept involves flexibility. You come across a new idea or activity or situation and you go with it. Well, Carol, maybe you can enlighten us on this. How can you make flexibility work in an environment that is historically very structured and very institutional?
Well, there are some things you must do. And you have a time frame that you give medicines in, and you have some appointments that you must make. But someone doesn't have to always have a bath in the morning. And we can wash their hair tomorrow instead of today, as long as they're basically clean and healthy medically. We want to give them as many opportunities to go to as many activities as they can. The key is flexibility.
Okay, so the rigid structure, and you mentioned this, Mary, waking someone up at 3 in the morning to get their medicine.
It still happens sometimes, but there's a reason for it, a very specific reason, and it's not going to be everyone.
I understand. Okay. Well, with less structure, is there a danger that essential tasks, as we talked about, that they're just not going to get done? Maybe they slip through the cracks, or?
I'm sure there's always going to be a story where someone said something did slip through the cracks, but it's not very often. We have to be flexible enough to know that we want to provide good care, but caring care. We want to be emotionally involved with our residents so that they feel it too. They know that we're trying to do the best we can for them.
Is it fair to say that in the past that in a nursing home setting that you got your bath at 8, you ate your dinner at 5, it was like keeping a kid on a schedule going through elementary school? Was it like that?
Yeah, absolutely. And there are some instances, especially with some patients who have like the mid-range dementia, who really find it important to have a structured schedule.
Okay.
They really require
So it's not
it.
completely thrown out the window?
It's not. It's,
Okay.
it's individualized. It's what each individual resident requires. And so you try and provide that. The key is trying to find out what they require.
I understand. Well, Carol, we've seen the results of your program and the footage we viewed today, and I'd like to show one more clip that I think really shows how satisfying continuous, meaningful activity can be for both the patients and the staff. Let's roll that clip now.
Are you ready?
I'm ready.
Okay. Oh, what a beautiful
morning.
Oh, what a beautiful day. I have a beautiful feeling.
Everything's going my way.
Yes! Wow, Mr. Wilkins. Woo!
Every time. Mr. Wilkins is a good sport there. Hey, we've just about come to the end of our formal presentation. We do have time to take some phone calls from you who are out there watching today. The number here, 801-924-6824. 801-924-6824. 6824. If you have any questions for anyone on our panel about this transformation to a new type of care facility, and specifically for care for people with dementia, they'd be happy to take your calls. I wanted to kind of go back to music a little bit, especially after we saw Mr. Wilkins there. It seems very effective, draws out a lot of people. Is it effective at all levels of functionality, though, for your patients, for people with dementia, would you say? Or only for certain people? Scott?
It can be. That's the trick. That's the sort of the take-home message is it's got to be individualized. And so certainly types of music different people respond to or have affinity for different types. Some people prefer classical, some people prefer jazz. And again, you've got to get to know your resident and their likes and their dislikes in order to effectively use it.
Carol?
I absolutely agree. Some of our residents just love gospel, and surprisingly some like country and western. So if you put Frank Sinatra on, or if you put on Motown, and some people are moving to Motown, that's not going to hit everybody. So you have to find out who needs what and put it in their plan.
Mary, you've obviously had some experience with this too. So.
Actually, I have. And one of our residents with dementia used to play jazz. And even though he had severe dementia, he could still play jazz piano. And we were very, very pleasantly surprised with that. And I think that what Scott and what Carol just said was it has to be individualized. And before, when we were talking about this transformation and that it's it has to be resident-centered, it's based on what the resident needs, what the resident desires. And so that's one of the reasons why we would have all these different types of music. And some may decide that they don't want to have anything to do with music. Right. It just depends on what the resident desires. It's about the resident, truly.
You have to be watching what they want and
Absolutely.
who reacts and that sort of thing. Well, I do want to go to a call. We have a caller on the phone. Tom from Little Rock. Tom, go ahead with your question.
Yes, I work with VA medical foster homes in Arkansas, and we have one veteran that's schizophrenic. He has had some history of aggressive behavior. The caregiver, foster home caregiver, tells us that we should not be showing this veteran any attention or taking him out or including him much because it makes his behavior worse in the foster home. Now, you know, I don't doubt some of that. We would have to spend the night to really, investigate that. But I wonder if you could comment on that with it supposedly should make agitation better. They're saying attention makes it worse.
That's a tough question.
It is a tough question without knowing the more details about the case, but I guess my first thought off the top of my head would be what do they mean by attention, and what is the, is he coming back overstimulated? Is it too much and then he's upset and up all night? Then we need to perhaps think about how the activities could be more soothing rather than excitational? That's not the right word. What's the word?
Excitable?
Exciting. Exciting
There you go.
activities, yeah.
Carol, anything else to add in your experience?
No, I think you got it.
Okay. Tom, are you still there?
Yes, still here.
Anything else you can add about this case that might
Well, I would
help
just
out
say
Scott here?
that it seems that any minor attention, like bringing him a cup of coffee from McDonald's that he likes, or just bringing him things in the home, and it just seems like the caregiver says the more attention you pay to him, the more acting out he does in the foster home. And he wants to be included, and he loves to socialize.
Still a tough question.
Yeah.
Mary, do you have anything?
Yes, what I'd like to share with you, I think that most behaviors are meaningful. There's something behind that. And I think, Tom, what I would share with you or recommend is that there needs to be two things. First of all, in doing this assessment of the individual, there needs to be an interdisciplinary approach to finding out what else is going on. The other thing is I do think, and I'm not sure it's something perhaps you have done at your facility, but some education, it needs to be ongoing education with the caregiver in the home so that the caregiver understands some of those behaviors a little bit better. And I think that would be something that I would share or recommend for you.
And getting them maybe to keep a log when he comes back so that you can get a better handle on what exactly are they saying is the behavioral problem. It seems to me that there's something there, but it's really hard to put a finger on without having the input of the folks on the ground.
Yeah.
Tracking it a little bit
I
better.
agree. I think educating our caregivers, and we do this as a group twice a year, but I think educating them and getting our recreational therapist out of the hospital to come help will maybe help us with this.
Absolutely.
Good.
Well, we wish you luck, Tom. Thank you very much for the call today.
Thank you very much.
All righty. Let's go now to another caller. We have Susan on the line from North Little Rock. Susan, go ahead with your question.
Hello, good afternoon, everybody. Hello, Tom from Little Rock. I am calling on behalf, I work on the CLC and recreational therapist. We have approximately 26 patients on that unit, and I would like to know what these ladies from Miami do with aromatherapy with the patients. I have been doing hand rubs and lotions with different scented lotions and checking with nursing staff prior to the activity to make sure it's not contraindicated, but would like to know more about aromatherapy type of activities, and also taking folks out into the community on the CLC. What are the ratio of staff to rec therapists to go along to assist, and how is that coordinated? And also securing volunteer groups in the city to assist, maybe perhaps bringing in canteen books. How is that coordinated?
Let me start with your question that has to do with the aromatherapy, and I think that Carol actually can provide some input into this as well. At our CLC, one of the things that we've started with aromatherapy, and we're not to the place where we desire to be, however, we started in our spa the same as what Carol did. And within our spa, we have the same aromas that Carol talked about in terms of the different shampoos, some of the oils that we have, along with the music, and we have a nice towel warmer. You know, just making it's not just about the aroma, but also about the environment. And so we look more holistically about how we can provide a good experience for the residents. Some of the things that we are currently doing is putting together, we're working with our recreation therapists to look at aromatherapy within our hospice unit. And we're just looking at putting together a guideline for right now. But for right now, that's where we utilize our aromatherapy, is in our spas.
And we're not doing much more, but we do use the aromatherapy in our spas and in the congregate bath for shower and bathing times.
Okay. Well, why don't we touch on, and she asked about also coordinating field trips, essentially, and what your ratio is for the number of staff or volunteers to the number of patients. Do you have a set rule on that, or is that flexible?
We don't have in Miami, we don't have a set rule. Again, it's based on the individuals going on the trip. We have some individuals who are very high functioning, they do very, very well. What I do require is that there is usually always one or two registered nurses to go with them. Sometimes our nurse practitioners will also go with the residents on those trips. That's extremely important to me. So what we try to do is make sure that whatever the needs of the residents are going to be, then we provide staffing based on what those needs are.
And I think the key that Mary highlights in that is the interdisciplinary nature. Mm-hmm. Again, it's not, it shouldn't be recreation staff. What's the ratio of recreation staff? It's what's the team involvement in the event.
Okay. Anything else to add? What Susan had questions about? She had a number of things there. All right, Susan, I hope we answered all your questions. Thank you very much for the call today. I want to go to a third caller now, Janet from Wilmington, Delaware, joining us now on the phone. And Janet, go ahead with your question.
Hello, everyone. It's actually Donna Talley from Wilmington, Delaware.
Okay. Sorry about that, Donna.
I'm a recreational therapist here, and wondering how you were able to get nursing staff to buy into expanding their duties other than nursing. There seems to be a lot of union issues involved with nursing staff doing something other than nursing duties.
This is Mary Nash from Miami. I am very pleased to say that we have a very good relationship with our union partners. And when we started our cultural transformation journey, we included them from day one. Some of the things they could not come to, but some of the things they did. So before I implemented anything, I made sure that they were aware of it. And that, I believe, has made a significant difference in the way our transformation has progressed. So I think that makes a big difference. In terms of the nursing staff and how do we get buy-in, I think that from the very beginning, I'm sure that most individuals were a little bit skeptical, but one of the things I shared is that once I made the change, from a leadership perspective, once I made the change, then I could be the model for some of our staff. And whenever they did something really well, they were always recognized and they were rewarded for those things that they have done. And to make sure that they understand what the vision is, this is what the vision is, so that we're all on the same sheet of music makes a big difference. And don't worry about that some may do pushback, or I think that it's a long journey. It's not something that's going to happen overnight, but you just have to keep your enthusiasm and your passion up for that.
And is it fair to say, too, that in any business, sometimes when you make big changes, you're going to lose some people. They are just not going to be on board with that. Is that fair to, in answer to Donna's question?
I really think it is, and I think that, you know, one of the things I think we've all come to appreciate after the last day or so of working together is that it's really about changing the philosophy. If you start at trying to change the tasks without people understanding and buying into the philosophy, you're not going to be successful. It's really about getting buy-in across disciplines that, yes, this is the right thing for us to do, this is the direction we want to move, and now how are we going to do that, and how is that going to affect the tasks that we provide?
In a practical note, though, she talked about, I mean, some employees are union employees, and there are rules that go along with that. I mean, is that a hurdle for implementing this philosophy?
Well, it can be seen as a change in working condition, but even with that, you still have the right to roll it out. You just have timing that has to be taken into consideration.
Again, it has to do with inclusion, including individuals in the process. And sometimes we don't include them in the process. We start the process and then we include them later on, and that's not the right place to include them. From the very beginning is where you start, is including everyone in the process, including those who are in the highest leadership, is really the best way to go about doing that.
Okay. Carol, anything else to add to that?
No, not from my level. We all participate as much as we can.
All right. Fair enough. Well, I want to thank everyone who called in today. The good conversation generated a lot more questions, I think, here. We're almost out of time for this broadcast. Before we go, we do have a few moments for some final thoughts from our faculty. Scott, let's go ahead and start with you. Any final words of wisdom?
I just would say that, you know, the process isn't easy, but appreciate the fact that this is the right thing to do, this is the right direction for us to be moving, and let's figure out how to get people to buy into the philosophy behind it.
Okay. Carol, what about you?
I think it's all about the people. It's about the residents, and it's about the staff.
Get them on board, and then they'll be buying into it.
I hope so.
Okay. Mary, what would you like to say?
I think if you just remember how important relationships are, I think that that is your solid foundation for propelling culture change forward. If you can build on relationships, that will do it for you.
Okay. Thank you very much. Before we go, I want to thank all of our guests, Scott Trudeau, Carol Phillips, and Mary Nash for being with us today. I also, of course, want to thank the audience for watching. And until next time, I'm Fields Mosley for the Department of Veterans Affairs.